So the next thing here we're going to talk about is a non-CME tech update. Thank you to all the sponsors for Korean American Spine Society. We really can't do these things without you. And the amount of support that we've received from all the companies really to keep us floating has been great. Some of the other meetings I've been in, we've had many existential crises given COVID. But the fact that everyone is here joining in is just fantastic. So I'm going to actually talk about sacroiliac joint dysfunction, diagnosis, and treatment. I think a lot of you guys have probably heard about SI joint dysfunction. You've seen the different new minimally invasive devices out there to sort of treat this. And I've got to start by saying I'm incredibly skeptical of certain technologies, especially when, when I was first introduced to this as well too. And sacroiliac joint dysfunction is something which I see more and more because I'm kind of looking for it. But before, it was something that was kind of unknown to me. And I'll start by saying that, let me just take control over this. Oh yeah. How could it be the SI joint? Because honestly, I never learned about I'm a neurosurgeon, okay? So the spine sort of stops at the sacrum, right? The orthopedists at least know where the hips are and where the knees are, right? So I mean, my knowledge gets limited and gets fuzzy after we sort of get out of the spine, the sacrum essentially. So I never learned about SI joint in training. No one ever told me what that was. I never saw SI joint pain in my practice, honestly. SI joint dysfunction was something I would say like piriformis syndrome, when someone just had butt pain after surgery. I couldn't figure it out and be like, sort of foo-fooed it and move people on. But I also never treated SI joint pain except for bolting people to the pelvis when I was doing long construct deformities in training. And they only said we did that for stabilization, but we weren't actually fusing the joint across there as well too. So really SI joint was kind of this mystery zone, which I really didn't think about when I was doing spine surgery for many, many, many years. But as you know, you'll operate on patients and some of the patients just don't get better. And the patients I hate the worst are the ones who come back with literally a pain in the butt, right? Because it's not radiating down the leg, it's no longer radicular. It's in the back, but off to the side. It kind of is in their buttock area, kind of on the side area. They're not in the midline spine. And these aren't the patients that you touch everywhere and they're screaming. You touch the midline, everything hurts, everything hurts. I mean, they really have a defined specific pain in an area that I don't know what is going on in that space. So awareness to me was really the key thing about the SI joint. Now, my awareness of SI joint pain, a lot of it came from people coming in saying, you got to do SI joint fusions. These are fantastic. When this first came out, I had someone who came up to me and told me, oh yeah, I do so many of these a month. It's crazy. I see it in everywhere. And honestly, that turned me off to SI joint fusion. I'm saying, all right, this sounds like too much like, this doesn't really sound like something very legitimate. I don't know what this is. I didn't even learn about this. Is this even a problem? But again, my curiosity was piqued because you think about it, the sacroiliac joint is, we'll move on to the next slide here. I mean, can it cause pain? And if you read about it, the sacroiliac joint actually is a very large joint. It's a large joint and it does move. It doesn't do a lot. Actually, its purpose is when you sit, it rotates the pelvis. So those little bumps on your bottom that you're sitting on, they move out of the way so it's not so uncomfortable to sit on them. And monkeys have really, really large, calluses on this area, so they sit on their butts really well. But humans actually have fairly soft, sensitive butts. And as a result, our pelvis mutates when we sit. Nutation just means it rotates a little bit, which takes the pressure off of that. So it doesn't move a lot, but it actually does move a little bit. And the SI joint also doesn't usually fuse. It doesn't ankylose. It'll degenerate and it'll start getting degenerative. But the TLDR version, it's a joint, so it can cause pain. As you know, every joint in the body can possibly be a pain generator. So it's definitely something that can be a pain generator. And if you actually look at studies about SI joint pain as a component of chronic low back pain, it's actually there. But once again, you got to know what SI joint pain is in order to actually, diagnose it and start treating it. But if you look at these studies, they actually say that chronic low back pain, when people say, I have low back pain, people come to me and say, I have low back pain. It turns out they have radiculopathy. I have low back pain. They have thoracic pain. They're very non-specific. So when people come in with low back pain, about 15 to 30% of people actually have sacroiliac mediated pain as well. Can I go back a slide? Oh. So the SI joint, because it's a joint, can cause pain because it can be functionally unstable. And it's a joint that's got bones and ligaments and things in that area that can cause it to destabilize and cause problems. But to make it kind of simple, there's three primary groups of patients that you'll sort of see who have SI joint dysfunction. And generally, they are people who've had prior lumbar surgery, Trauma, people slip and fall or do something that will irritate the joint. That's one issue. And then people that are postpartum, because you get a laxity of the joints, and those things can cause irritation as well too. And it runs the gamut, because I've seen people as young as 15, 20 years old, and people up to 90 years old. I myself have actually personally experienced SI joint pain, because I sit looking at the TV with a computer to the side, and it actually upsets my SI joint. I didn't realize what it was, but you get like this dull toothache in your butt, and every time I change my position, it gets better, but it can be pretty annoying. And I sort of figured out, wow, that must be SI joint pain. Nothing bad enough they need surgery for, but it also turns out that people have had some lumbar fusion. A lot of them have back pain as well too. And about 30 to 40% of these people have SI pain as well too. And I'll sort of talk about how we identify sacroiliac pain. So if you actually take the spine and you fuse L5-S1, you actually get 52% added movement in the SI joint, because you're no longer sharing that load below. So you can imagine like SI joint pain is almost a form of adjacent segment degeneration, where instead of just going up, it's going down and out the side. But you don't look at the SI joints. I don't. You can't see a lot of change on the SI joint, but a lot more force is going to the SI joint when doing L5-S1 fusion. I mean, if you do a C5-6 discectomy, 4-5 is going to have pressure, 6-7 is going to have pressure. L5-S1 fusion, we just look at the L4-5. It turns out the SI joint is also that adjacent segment that gets a lot of force. You do L4 to S1, you get even more going through the SI joint. Turns out if you fuse the SI joint, you don't get a lot of added motion, because the hip and the spine move a lot inherently. So fusing the SI joint seems to be less of a problem than fusing the spine itself. So that can get you thinking about why you may be having SI joint problems after doing lumbar fusion. So moving on, when you're doing multi-level adult spinal deformity surgery, they have shown also that SI joint pain does significantly increase. And again, this is just a follow-up from what I just showed before. Is like before we're showing the amount of force, the amount of movement that you have, but the actual amount of SI joint pain that's been quantified after you do a fusion at multiple levels, it clearly goes up and up and up, because you're putting more force on that segment, right? And the hip itself is moving around a lot, but the SI joint, it really doesn't have a lot of support or a lot of movement there. But there are a lot of challenges with SI joint diagnosis, and that's the first thing. First, you got to acknowledge it exists, and then you actually have to figure out, well, how do I diagnose this, right? So the reason is that SI joint symptoms overlap a lot with the lumbar spine and the hip. You've got the lumbar spine, you got the SI joint, you got the hip, and a lot of times these symptoms overlap, and our job as a spine surgeon, obviously, sort of tease that out, right? The other thing also is that the imaging studies of the SI joint are inconclusive. Sometimes you'll find somebody with a CT scan with just a horrible looking SI joint. Wow, that's great. I will tell you the vast majority of people with SI joint pain that I treat and possibly operate on, they actually do not have a significant amount of pathology. I mean, they have like joints that don't look perfect, but they're not your typical ankylosed, osteophytic, hypertrophic, totally worn out joints, but they do well with treatment. Here's something that you can look at. When someone comes in with, say, a disc herniation, they'll have back pain with radiation down their leg, right? If they have facetogenic pain, they can also have back pain radiating down the leg. Turns out with SI joint pain, you can also have back pain and buttock pain. It usually doesn't radiate down the leg as much as a radiculopathy, but it can. It also can radiate anteriorly, because the SI joint is quite large, and then you have groin pain as well too. So if someone comes to me who has a normal looking MRI or relatively looking lumbar MRI, who has pain on the SI area that radiates into the buttock and seems like a radiculopathy, like an S1 or an L5, but doesn't go too far, has positive tests as well too, I'll think more it's an SI problem. Hip joint problems can also overlap as well too, but hip joint problems, you can usually tease those out, because you got to do focus tests on the hip. So, me as a neurosurgeon doing neurological testing, now I'm doing a lot more testing of hips, SI joints, to sort of rule those pathology out as well too. Recently, I saw a patient who came in who just had radiculopathy, but it was weird. And, I was doing a FABER test on her, and then and some other provocative tests, and it was very clear she had a bad hip, and she had a horribly bad hip. Sent her out for hip surgery, which is great, because I was thinking about doing a decompression on her, which would have been the wrong move. So I think it's actually good to sort of think about new things, because it makes you a better clinician, I know for a fact I've misdiagnosed many people over the past going forward. Now, the history is very important. What I mentioned was trauma. A very common cause of SI joint pain, believe it or not, is a rear end accident. Because what do? You slam on the brake with an extended leg, you get hit from the back, your leg gets punched back, and where does force go? Your SI joint shifts a little bit. That's a very common way that people actually start. You miss a step, you land the wrong way, you get force transmitted straight up your leg, and all of a sudden it felt like someone just stabbed you in the back off to the side, not in the axial spine, but on the SI joint. That's actually a not uncommon way for things that people start, or they land on their butt on one side. Or like I said, I twist the wrong way, so now my SI joints are having imbalance of forces. Prior lumbar fusion, definitely, that's something you can think about as well too, and then pregnancy as well. But then again, the complaints that they have are very similar to a lot of the other things that you do. But there are other things that they do which are kind of unique to SI joints. Rolling over in bed is very painful if you have an SI joint problem. That's not very common with people that have a radiculopathy. Hip pain possibly, but usually it's on one side. But rolling over causes a lot of pain in the SI joint. A lot of people, that's why it's very hard for me to stand up. When I get from sitting to standing, oh my God, I feel old, I feel this horrible pain. Once I get up and moving, I'm okay. That's like stenosis. Stenosis, you get up kind of slowly, it doesn't hurt. You start walking and then it really starts to bother you as well too. But transitioning of movements, because remember, the SI joint, what it does is it rotates the hips when you go from sitting to standing, and that's what it does. So those movements and those changes, moving up and down stairs where you're pounding on your leg, putting force, not just through hip, but through that SI joint, causes pain. These are little nuances that made me appreciate that this is kind of different from what I see with people with radiculopathies and other back pains as well too. And then what helps? I mean, some people literally will just stand on one leg, will stand on the other leg. A very common problem I have is post-discectomy or post-radiculopathy. I have someone come with a discectomy on the right side for a chronic radicular pain. They will come in post-op, their leg is better, but their left SI joint is hurting now because they've been standing on that side for so long. So those guys, I mean, I don't operate on. I just tell, oh, you got SI joint pain, it'll go away, once you start walking normally. And that happens a lot. It's interesting, you'll hear people who have like hip pain contralateral to the other side, and you're like, oh, that's because you've been limping for a while. A lot of that is actually SI mediated because they've been on one side for so long. So what are other ways besides the history to identify this? The other thing you can do, there's something called the Fortin finger test, which is kind of funny. It's like if the patient takes their finger and points to their SI joint, then it's possibly SI pain. It sounds silly, but here's the thing. It's actually very good because the patient, if they don't point, okay, where does it hurt? Just point to it. They'll point in the middle of the back, that's not SI joint. They point to the bursa, they kind of point to this general area, no. But if they point specifically at a location where their SI joint is, that's actually not bad. The actual test is you have to ask them twice. So I'll ask them at the beginning of my exam, I'll ask them at the end of the exam, and I will press on it. And literally, if they have bad SI pain, it's like a button. You will make them yelp. So I'll sort of push around. Now, if they yelp everywhere you press, that's not good, right? But then if you push in some places, but you press right on their SI joint, like, oh my God, that's the spot. That is actually a pretty good indicator that you may be dealing with an SI joint problem, okay? Again, if they're hurting everywhere, a totally different story. So physical exam, pretty straightforward for the other things that you're doing, palpation, range of motion testing. What's really, really important, like I said, is I do a lot more hip exams than I did before because I want to make sure if it's not the spine, it's not the hip, I'm sort of zoning in on the SI joint as a possibility. So I'll do FABER tests, I don't really do the FABER too often. I'll usually do the other tests as well too. But these are just basic tests. Take the leg, move it around, test their hip joint because as you know, hip joint pain mediated by mechanical movement is something that you're not going to find as much with a spine with pathology. And it's very easy to get an x-ray or something and see, and oftentimes I'll pick up a pathology there. So when you're doing SI joint in particular, palpation over the PSIS, basically pushing that level, you literally find a spot that makes them yelp. Single leg stance, they have them stand on that leg, like, no, I'm not going to stand on it. Have them hop on that leg, no, I'm not going to do that either. Then you know that, there might be something going on. Gait assessment as well too, when they're walking around, they're hobbling a little bit, they have this kind of like lurching gait because they're trying to protect that joint when it's very bad. Those are very, very common things. So the other thing in addition to that, history, localization of the pain of the area, is there are actually provocative testing for SI joint pain. And these are actually pretty easy to do. And if you have 3 or 5 of these, and you've got something like 80% discriminatory power that they might have an SI joint problem. And you can do these, and which is basically you can distract the joint, push the joint, do a compression on the joint. Very straightforward test that can be done. I taught my MA and PA to do these as well too. These are actually pretty good as well too. Now, it's true that these are not perfect, okay? None of these things are actually perfect at all. And, when you press in different areas, you may get pain from different sources, but in combination, these sort of lead you towards thinking maybe there's an SI joint problem. So if you look at the 5 proactive tests and you perform them in combination, don't just do one. You don't press on them and say you got an SI joint problem. You do these things. There actually is a high degree of sensitivity and specificity. Because I'll tell you that SI joint surgery, which I'm sort of getting to at the end here, it's kind of like it either works or it doesn't work. So you want to make sure it works, that you've identified the patient properly. Most patients, that's been my experience. It's either like, wow, that helped a lot, doc, or didn't really help a lot, because I think it's a diagnosis issue. So if you have a positive history, you have a positive Fortin test, you have positive provocative testing, the next thing to do is go to SI joint injections. And injections are incredibly important, okay? Injections, when you look at these things, they say SI joint diagnostic injection is a reference standard. I do send people for injections. ISAS and NAS both support using this as well too, and it's incredibly important. And I don't tell them what to expect. I say, go get an injection and come back and let's talk about how you are. And I do that with most of my injections because I want to make sure that they're not too biased. And ultimately, this is what happens is people come in with SI joint, and I think that that's what they have. There's a continuum of care. And what I will tell you is a minority of my patients go to surgery. I probably see SI joint pain in at least one patient a week in my practice. Many of them got gone undiagnosed for a long time. I get them on the non-surgical management thread, and 80% of them never see me again. They get better. Some of them have had this undiagnosed for years, and they get better, and they love me, and they think it's awesome. It is rare that they come back and they have surgery with me for SI joint, which is very interesting to me. I think it's a diagnosis thing rather than, I need to treat you for this. Once you sort of improve them, they get better. High-dose non-steroidals are very helpful because it's a big joint. Physical therapy focused on SI joint, no longer radiculopathy hip stuff, is very helpful. SI joint belt, it's like a belt you wear around your hip. You buy it on Amazon for 15, 20 bucks. That can help a lot. A combination of these things are very helpful. I send them for injections. They go get an injection. They do very well from the injection. They're pretty happy with that. And then they end up getting a radiofrequency ablation, which is also very good as well too. So the radiofrequency ablation can actually buy them a lot of time. So it's very few patients that actually come back to me saying, okay, I failed everything, but everything did work. What's the next step? So I found that to be very interesting. So I worked with my physiatrists and trained them as well too to do very good injections for me and to do very good treatments for me. And as a result of that, these patients end up doing very well. They're very happy because someone's figured out what's wrong with their pain. It's treatable, and it doesn't involve a spine operation or hip replacement. So I think that provides value to patients for sure. Now, let's say the patient does come back though, and they say, I've done this for like 2 years. Literally, I've patients come back 2 years later. I've done the injections. They work great for a while, but if they're not working as well, both sides are kind of hurting right now. The ablations aren't lasting. What's the next step? What can I do? And then I say, well, if you've passed all those things, you may be a candidate for surgery. And there are surgical options, which are actually kind of nice, because in the old days, the surgical options were very invasive and scary because that's just how we sort of treated these things. And now, somebody is messing with the slides. Okay, surgical treatment. But now you can actually do this in a much less invasive way. Now, there are many options out there, okay? I mean, I like iFuse because they've been around the longest time. They have triangular implants. I think that inherently, relative to round implant, resist rotation. They've had the most experience in sort of these things as well, too. Their technique is pretty well refined, and they have a lot of data to support their procedure. So the iFuse piece, I'm not going to go into details of procedure. If you're interested, you can learn about this. It's not that hard to learn. You guys can do complex spine surgery. You can figure out how to do this. There are nuances of technique. You need to learn a little bit about it, but it's a very straightforward operation that takes about 30 minutes to 45 minutes, and the patient usually goes home the next day. So if you look at this, the steps here, you make an incision, you do localization. It's all done under fluoro. They have very simple tools to go through this. It's relatively safe as long as you're careful where you place the implants. They recommend placing 3 implants, and generally that's, you're able to do that. As you develop more experience, you have more understanding of actually which anatomy is good or bad, and a lot of it depends on the rep. And this is very, like many things, it's very dependent on the reps that you have as well too. So here's an example of a patient I just saw yesterday. She has degenerative spine disease, but that wasn't her pain. She actually had really bad SI joint pain, basically on one side. ended up basically doing the SI joint fusion on her, and she's doing very, very well. She still has some chronic back pain, didn't fix that, but the horrible sharp stabbing pain she had in her SI joint is much better. She's very pleased about that. So she's, she's a happy camper. But she had gone through evaluation, treatment, et cetera, and it was probably a year after I first saw her before I actually did surgery on her. So there are a lot of trials that have been done for SI fusion, and we could debate and argue these for a long, long time. I've been on both sides of the debate actually regarding SI fusion, but really, a lot of the data that comes out for SI fusion comes from this company, comes from this data. It's kind of like NuVasive and XLIF. A lot of people in lateral surgeries, but most of the data was based on, NuVasive XLIF implants. Same thing here, SI joint data. A lot of people using this data to support SI joint surgery, but most of it came out using these implants from this company. And I think they have a very, very good support, which is good, so you can do these things safely. Because with all operations, you can do them unsafely. And also, if you're a hammer and you're a nail and you see nails everywhere, you want to do this on everyone, you can, but then I don't think you're going to get the results that you really want. So again, lots and lots of clinical evidence for this, and they will say that this is the only SI joint fusion device that's cleared with the FDA with multiple randomized controlled trials and prospective clinical publications. So here's an example of a patient that I did who basically had an outside fusion done by an outside surgeon, another institution. Came back with really bad had a really bad severe pain in her hip. 2 years actually of treatment. And finally, was decided it was the SI joint was a problem. The outside surgeon actually referred the patient to me for evaluation and treatment. So I did her SI joint surgery on one side. She actually is doing very well. She has pain on the other side as well too. So I'm going to take her back for surgery actually in a couple of weeks. I just saw her yesterday. She was healing well from one side, and she said, "Yeah, all that horrible pain on the right side is gone. Now I have this pain on the left side, which wasn't as bad, but if you can help me with that too, that would be fantastic." So I'm going to take her back and fuse the other side soon. Again, she had previous surgery. Actually, her last back operation was like 5 years ago, and she has been dealing with chronic pain until our doctor finally said maybe it's the SI. Went down that path and realized it was. She responded well to it, but then said, well, I'll send you to someone who does these procedures. I'll send her to see me, and she's doing well, so she's pretty happy. Here's a patient I actually did as well too. These are not my operations. They came to me having had prior lumbar decompression and fusion and having prior hip replacement. So once again, if you look at this person, they got hip surgery, they got back surgery, they have ongoing back pain. Where's the pain coming from? Well, the only joint that's mobile between the previous operations is the SI joint. And this isn't every patient by far. Don't get me wrong. A lot of my patients, just because you come in with this picture, you're not going to get an operation. But this gentleman had bilateral SI pain for years. Once again, it was very clear it was a diagnostic testing and evaluation. So I went ahead and did bilateral SI joint fusions on him after he had failed conservative treatment, and he's doing very, very well. And it's beautiful about this operation is, 30-minute surgery, go home the next day. It's not that it's not that invasive. It's patients pretty happy with the outcomes, much better than some of these other operations as well too. And when done in the right people, they do very, 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 very well. So the other thing also that's interesting is if you think about the SI joint as well too, a lot of time we have long construct failures, and to shift gears from just sort of basic sort of sacroiliac stuff, but also sort of what else is sort of out there is, a lot of people, you'll put in these iliac bolts, they'll sort of loosen, you'll have failures, and then they got bad bone in the area. But again, you're putting a single bolt through the SI joint, which is basically a rotational pin. You're not doing anything to actually stabilize across that joint, and that can lead to problems as well too. There's a lot of literature, published by ISSG showing that pelvic fixation fails often, just by nature of the beast. So how are ways that you can improve that? Because when we stop at S1 sometimes, but then we'll go to the pelvis, but even go to pelvis, sometimes you can fail at the pelvis as well too. And there is failure of the lumbopelvic fixation, a long construct, and a lot of people have fusions, and major failure rate that was published is up to 12%. And a lot of that has to do with, revision surgeries and, not restoring spinal balance. But what could you do to kind of like stabilize the joint of the problem? And this is kind of an additional thing to sort of think about. There's a new trial coming out is when you put in your pelvic bolts, you could also basically supplement them possibly with a large SI joint bolt construct and run them parallel to your iliac screws. And this is a new concept that the company has sort of come out with as well too. It's very interesting for those of you who do long constructs and want to think, wow, what can I do? Right now, some people do double SI to S2 bolts or something like that. But here's an interesting option that you could think about as well too. which is once you've had a long construct, you can put in your S2 alar bolts or you can put in your iliac bolts, but also at the same time, there's enough room, as you know, you can run a parallel bolt across with that. And this implant is something which is actually something kind of interesting that you could do. And this can be done pretty easily when you're putting your S2 alar screws right above it. You can actually, there's enough room, if you do what's called a teardrop view, to actually to place parallel to your S2 bolt another pathway. And through that pathway, you can actually do a sacroiliac fusion across side, putting in one of these very long, custom-made bolts across that area to help supplement the construct that you do. Now, this isn't for everybody, but if you're doing S2 alar bolts, and you'll know that there is actually room to do this. And once again, the bolt just traverses the space, but doesn't actually do anything with that area. And there's also a little controversy about S2 alar screws versus doing the iliac pelvic fixation as well too, which is better and which is just more convenient. But this actually sort of gives you an additional stability across there. Now there's a study being done to confirm whether or not this actually will pan out and be good, but from a conceptual model, you can think this adds an additional level of stability. And there's always that question when during iliac fixation is, are you actually really fusing the joint or doing anything to the joint? The answer is not really, right? So anyways, so here's an example of a patient who basically had a revision surgery done from the lower spine and went to the upper spine here and had the S2 alar bolts put in for fixation and had large fusion bolts put across in order to truly accommodate an SI fusion at the same time that you're actually doing a stabilization and a fusion across the backside of the spine. And that actually might be kind of an interesting application for technology as well too. But what I really, really want to sort of summarize with is, could the pain be the SI joint? Now, don't get me wrong, it can't be everybody. I had a patient come to see me who had SI fusion placed and she still had pain. I did an MRI of her spine and she had a large L5-S1 disc. So you got to be a spine surgeon, but sort of think a little broadly, especially if you're a neurosurgeon, look into the SI joint, look in the pelvis, be more diagnostic. Consider the SI joint as a potential pain generator, not necessarily the only one, but one of the things that could be possibly out there. Learn how to diagnose this. It's not as cut and dry, just like radiculopathies, just like hip disease as well too. I'm making this very simple and straightforward based on my experience. Confirm that diagnosis. If you can't get confirmation of that diagnosis, then don't bark up that tree anymore. And I want to emphasize only a minority of patients will actually go on to surgery. I mean, I literally diagnose SI joint dysfunctions as a service to my patients, and they love it because they get better. But only a small number actually needs to go to surgery. But in my experience, at least, surgery does seem to work very well in the subset of population with symptomatic disease when the diagnosis is mostly correct. So thanks for your attention, guys. Appreciate it. If you have any questions, feel free to send them over.